Doyle. I'd like to thank the Academy for putting together such an illustrious program on a procedure that is not yet FDA approved. These are my financial disclosures, and I do have financial interest both in Alcon Wavelight, which is the excimer and femtosecond lasers I'll be showing you, as well as Avidro and Cirrus, which are companies involved with collagen cross-linking. And the perspective you will hear from me is that of a cornea surgeon of 18 years now, having to deal with young keratoconic patients, initially by performing cornea transplants when contact lens trial failed, and then having the headache of visual rehabilitation. I went from New York, where I saw about 50 keratoconic patients a year, to a country where I see about 1,000 keratoconic patients a year. And this is a single physician practice. And we caught on Theo's idea early on. We started cross-linking keratoconic corneas in our practice in Athens, Greece, and saw, you can see this publication from the Journal of Cornea several years ago, getting a cornea that's quite steep and probably a transplant candidate at the time, 2002, into a much flatter and stable a year later version. And this is the change, but this patient still had issues with visual rehabilitation. So after failing contact lens wear and having difficult time at the time with intracorneal ring segments, we decided to attempt the forbidden, laser a thin keratoconic cornea. And I understand how everybody feels about this, but if we did not achieve reasonable visual rehabilitation, this patient was willing to undergo a transplant anyway. So we used the proprietary software by Wavelight at the time to perform a topography-guided, not PRK, but normalization of the cornea. I'll be talking a little bit about this, in order to reduce the significant irregularity of the cornea and be able to offer this patient some type of visual rehabilitation. Well, the experiment succeeded. You can see this cornea here. It's still irregular, but the patient has functional vision of 20/30 with a soft contact lens, while the 2-year interval shows the other eye progressing in ectasia. During this process, we also proposed the higher fluence of collagen cross-linking, and it was in this meeting in 2008 that with the means at the time, we went up to 6 milliwatts, and now after all these years, this procedure has evolved to what we call the Athens protocol, where we perform initially a PTK, 50 micron, 6.5 millimeter, and this is important, use the epithelium as a masking agent, then a very frugal topography-guided normalization of the cornea, not to exceed 30, 40 microns of tissue at the cone, followed by mitomycin C and high fluence collagen cross-linking. My golden medium is about 10 milliwatts for 10 minutes. And we've had a milieu of publications, book chapters over these last years on our technique. We're able, just to briefly run by it, we're able to import 4 different type of topographies, and I'd have to disclose that this is not yet FDA approved either, any type of topography guided treatment in the United States. So the patients I see in New York, I cannot offer them this. Then choose, for instance, here from a device that's similar to a Pentacam, it's called Oculizer 2, perform the PTK, and then the topography-guided PRK. I'd like to draw your attention here that this treatment is a part myopic treatment seen here, which makes sense that the tip of the cone, flatten the tip of the cone, but please pay attention to this partial hyperopic treatment that's away from the cone. And its purpose is to elevate the very regularly flattened paracentral area of the cornea. So the result of this intervention, and I'm sure you're going to start brief video here, is the PTK.
The topography-guided PRK, again, a combination myopic and hyperopic treatment, seen here with the EX500 excimer laser. Here, mitomycin C, 0.02 milligrams per ml for 30 seconds. This is the BSS that will be followed by 0.1% riboflavin. For the Athens protocol, we use a standard of 10 milliwatts for 10 minutes. We use riboflavin drops every 1 minute for this 10-minute duration.
Fulfill the procedure. We just added the procedure the use of a small disc of amniotic.
We're ready to start the PT.
Pain and visual rehabilitation. When we compared cross-linking first and 6 months later, this intervention to doing them combined, we found that there's a significant synergistic effect. And here you can see a very advanced cone. Very hard to believe that 10 years ago I would even consider it an alternative to cornea transplantation for this patient that is somehow normalized and is able to function with 20/40 vision after this procedure with a soft contact lens. This is a much nicer example here. You can see the pentacam here picks up keratoconus 1 after the Athens protocol. This cornea is picked up as normal by the pentacam. And just to go back for a second, I'd like to draw your attention. I propose this a means to evaluate keratoconus and visual function and not visual acuity and refraction. I'll draw your attention to the Ambrosio indices of topometry. And we have found that the ISV, the index of surface variance, and the IHD, the index of height decentration, are the two pivotal indices for visual functions of these patients. And these indices are halved by this procedure of topography-guided manipulation and high fluence cross-linking. This is a gentleman who was a helicopter pilot, developed post-LASIK ectasia. This is probably the star case of all this series. We've done over 1,500 eyes in Europe, and he's currently in active flying duty. Just to give you the point, this is a patient with probably refractive error of plano before he started and ended up with about a diopter of myopia. This is not a refractive procedure. Sometimes in normalize this cornea, we induce myopia, so the goal here is to increase best spectacle corrected visual acuity and avoid cornea transplantation, enhance visual rehabilitation. You cannot compare these data to your LASIK or PRK practice data. This is our experience. We're presenting this tomorrow, long-term follow-up, and you can see that this procedure is pretty lousy in predicting uncorrected visual acuity, but is extremely efficient in predicting best spectacle corrected visual acuity as all patients improve at least 1 line and up to 4 lines in best spectacle corrected visual acuity. And just a line of caution, keratometries throughout years, and in some cases we have 6-year follow-up, tend to flatten even more, probably a re-expansion effect of the peripheral cornea. Thus, you have to understate the refraction, even if the refraction is very small. So you cannot treat the full refraction because expect these corneas to flatten further. Now, just to briefly fly through some other applications, we proposed using a femtosecond laser-created pocket to introduce the riboflavin and thus not have to take the epithelium off. And this we published in 2009 in the Journal of Refractive Surgery, and it has gained some success. And back in the ESCRS meeting in 2007, we proposed using this high fluence cross-linking as a prophylactic treatment in LASIK. And now with means such as the Avidro device, it's become more efficient in performing it in all high-risk LASIK cases, which would be younger patients, myopia over 6 diopters. And our group in Athens has just published this month that probably LASIK extra would be a requirement in all hyperopic LASIK cases, because bizarrely here, the procedure does not flatten the hyperopic steepening that we perform, but stabilizes that loss of steepness that the hyperopic LASIK cases have through the years. This is a contralateral eye study we're publishing this month in the supplement of the Journal of Refractive Surgery, and the dark blue line are the LASIK plus hyperopic eyes, a stunning difference to the fellow eyes that were not cross-linked. Of course, this comes with some cost. These eyes do show delayed epithelial healing, so they too do require some babysitting in these early days. You can see here, these look like angry PRK eyes, and this we found this in about 30% of the patients. As far as intacs and cross-linking, I have limited experience with this, but there is growing literature. Intacs are the second choice for European surgeons to a excimer laser intervention on the cornea in combination with cross-linking. And this is an intact patient before and after cross-linking with some limited improvement. This is a young gentleman that worked with us in Athens that has gone to Cairo, and he's running a very interesting study, doing a contralateral eye study, Athens protocol in one eye in keratoconic patients, and cross-linking and intacts in the other eye. And although the Athens protocol eyes appear to be more predictable in improvement in best spectacle corrected quality vision and glare than the intact eyes, the Athens protocol eyes have the significant disadvantage of having a longer recovery and a significantly painful first night. And I will close with our latest work on this. This is a femtosecond laser astigmatic keratotomy performed with the LensX device here. You can see before and after. This is a cornea transplant patient. Some of my cornea transplants do have high astigmatism. I apologize about that. And you can see there's some improvement in the astigmatism and this eloquent way of titrating the astigmatic keratotomies, about 3 diopters here, but when we cross-link these incisions, high fluence cross-linking, we got a stunning additional 6 diopter correction to that. So we use this as
Hello, this is John Kanalopoulos from Athens, Greece. A fascinating new procedure. This is a very high astigmatic result in a penetrating keratoplasty. We're going to use the tremendous Lensex option you see here, cyclorotating, the 6 o'clock mark, and then centering on the pupillary center to perform these very small arc 30-degree astigmatic keratotomies at 85% depth, superior and inferior done, and now we're going to see these on slit lamp.
50%. So I think this will be a great improvement. Phakic IOLs is another option to treat anisometropia. I've used both the Artisan and the Cachet lens and the ICL. And I will close with the fact that this combination techniques are not refractive treatments, but rather therapeutic treatments. We have found our Athens protocol being the most efficient, although NTACs are favored by other international surgeons, and CXL may have many more indications in cornea anterior segment surgery. And I thank you very much for your attention.
No.